Hello and welcome to Fertility Talks, the Therapie Fertility podcast. I'm your host, Ranae von Meding, and this season I'll be sitting down with none other than Medical Director of Thérapie Fertility, Dr. John Kennedy. Each episode, we will be chatting all things fertility, trying to conceive, and much, much more. We hope that through this series, through honest conversation and information, we can strip away some of the stigma that sometimes comes hand in hand with infertility and fertility treatment in Ireland. Welcome back to another episode of Fertility Talks. And this week we're going to be chatting about infertility.
Super.
What causes it and how do we treat it? So let's talk. What is infertility? What is...
Dive right in. So the World Health Organization, we take our cues from them. They say it's a disease. It is. And that's really important to classify it as a disease in the first instance, because it gives some agency to people who are suffering from it. You suffer from a disease. It also puts pressure on legislative bodies, governments, to apply funding for treatment and resources if you acknowledge it's a disease. Infertility is being unable to conceive after a period of trying. So how we usually break it down is if you're over the age of 35 and you've been trying for 6 months, or if you're under the age of 35 because something magic happens to you on your 35th birthday, obviously. But if you're under the age of 35 and you've been trying for a year, we call that infertility.
Now, just to be really simple, what does trying mean?
Unprotected intercourse, regular unprotected intercourse. And we can circle back into that because I think that's a real kind of can of worms question. How long have you been trying for?
And how often and all of that.
So I kind of like to shy away from the word infertility a little bit. It's very obvious that if you've had your testes removed, if you've had your ovaries removed, if you don't have a uterus, you are infertile. The fundamental building blocks. It's not going to happen no matter how often you try. The vast majority of people are subfertile.
And what does that mean?
It may be less likely, not impossible, but less likely for you to conceive in any given time frame. So when you're thinking, if you're thinking in terms of I am infertile, like, okay, both your tubes are blocked or gone, you are infertile. Your tubes are open, you've been trying for, say, 2 years, it hasn't happened, I'm infertile. Well, you mightn't be infertile, you might just be a bit unlucky. So how you think about those should have an impact on how you might manage it and how you might approach it. But generally we say 6 months or a year. But honestly, we'd like to think that things are progressing a little bit, and awareness of fertility, not awareness of infertility per se, but awareness of fertility, the causes of issues that may arise, when to start thinking about it, is growing. And you should be having an awareness of that before you run into problems.
Sure.
I think. How many people run into problems? 1 in 4 to 1 in 5 couples.
Yeah, generally. That was my next question. How common is it?
1 in 4 to 1 in 5 couples usually. That's what we say. 90%.
That's massive.
Yeah, but it's a bit of it's a broad number. Most couples will conceive. 90% of couples, this is an old statistic, and I really don't know how reliable it is anymore. 90% of couples conceive within the first year of trying, 95% within the first 2 years of trying. So it's half of the rest, if you follow me. After that, in years 3, 4, and 5, you start hitting the law of diminishing returns. So if I see a couple who have been trying, say, for 7 or 8 years to conceive, and I've never, that's a big red flag for me. There's something going on.
Sure, there's probably a huge difference between trying for a year and trying for 7 years.
Exactly. And well, I mean, I think for a start, that comes back to that word trying. Month 1, month 2, month 3, you're diligent. Month 10 through 12, you're less diligent. I can only imagine by year 7, you're probably a little bit
apathetic to the trying.
Run out of steam.
Yes. And just to kind of circle back, so say if a man and a woman are trying, what is the likelihood that they would get pregnant month 1? Because I think sometimes people think you do it once and you're pregnant.
Yeah. So much knows people don't like to hear this. The number we think is about 17%, 17. So it's not high.
No, it's very low.
That accumulates. It adds to itself every month, so it builds up. But it's not a high number to start off with. And it means you're more likely not to get pregnant than to get pregnant. Now, part of that is due to the fact that an awful lot of pregnancies will fail before they even become pregnancies.
And you'll never know.
Exactly.
Yeah.
So total miscarriage rates, we quote miscarriage rates being 20-25% in young people, but it's actually probably close to 50-60%.
Because a lot of people might miscarry and you would just think it's your next period.
Or the embryo fails before it ever implants on that day 5. But I mean, I suppose technically it made it to the womb, didn't implant, all the rest. Where do you call pregnancy? Okay,
so we've talked about this, how long someone should wait before they start looking for some answers or talking to a fertility specialist.
So you say, you apply that, the general rule of thumb is that 6 months to 1 year rule. I don't like that. I'm biased. I've put my hand up. I work in a field where all I see day in day out is couples who are struggling to conceive, and their universal mantra is, I wish I had started earlier. I wish I knew then what I know now.
So how could we change that?
Awareness, education, early testing. For males, it's a semen analysis. For women, it's a blood test looking at the ovarian reserve.
And both of those things are very straightforward, right?
Yeah, they are. There's capillary testing, little finger prick testing for AMH now, and it's very reliable. And I think, in as much as AMH can never be said to be very reliable, but I wish people would do that earlier. I really
And what
do.
would that information, so say if a couple presented to you, they had AMH and semen analysis done, and then they got the results back, what could they do with that information?
Well, probably nothing, which is the right answer. It's the right. Are you trying?
That's what we would hope for.
Are you trying to conceive? No. Then off you go. Well, these results would suggest to me that, as of now, you don't have any problems. You're unlikely to run into problems from these points of view over the next while. So
hopefully when you are trying, it
won't be an issue. You know, it's like any screening test. It's like having cervical
or colonoscopy
smear,
or whatever,
or a mammogram or something like that. You're doing it in the hopes that it'll be entirely normal, and you forget about it for a while, and then you go back to it and you do it again in the hopes that it'll be entirely normal, and you forget about it for a while, and you just you incorporate that awareness of your fertility potential into your life. What do you do then if the result is abnormal? Well, then you manage that. You either go on to second level testing, which is what you do with most screening tests. If you get an abnormality, it doesn't mean there's anything wrong. It just means maybe we need to look at this a little bit closer. And if it does turn out that you've got a low reserve, if it does turn out that there's a low count or there's another issue, then if you aren't actively trying, it affords you an opportunity to be proactive. Maybe if it's a sperm issue, maybe there's things you can fix in your diet, your lifestyle, smoking, alcohol. You can bring your sperm count back up. You can get an awareness. Are there other stressors in there? Things can get better. If your ovarian reserve is low, that's a difficult one to fix, but you have agency again over it. You could elect to go, okay, I don't want to have children now, so I might freeze some eggs. I might be aware, or I might think, well, I am in a committed relationship. I wasn't planning on starting a family for another 2 years, but really what was stopping me from bringing that time frame forward? And if it's something critical, fine. If it's something like, oh no, I want to progress my career, I want to do this, that and the other, well then you at least get to weigh up those options side by side. And it's seldom as clear as, if you want to have a child, you have to do it this year. It's seldom that clear. But if you parse it out in those terms, that can be a useful thought exercise, I think, to tell you, right, what's important.
Yeah.
It's all fun and games till you get told what you can't have.
And is there any like physical signs of infertility before someone would get to the kind of testing stage, or if they haven't really even been trying?
Sure. So there are conditions. There's 2 conditions that are probably worth talking about that women have. One is polycystic ovarian syndrome. The other is endometriosis, both of which could potentially have symptoms.
And how common are those?
Oh, very. I mean, well, PCOS, polycystic ovarian syndrome, suffers from a lack of clear definition. So at its most broad definition, up to 40% of all women could be said to have
I'm pretty sure I was
PCOS.
told I had that at some point.
And everybody I meet who's been given a diagnosis of PCOS tells exactly the same story. I was told I had PCOS, and then I was told I didn't have PCOS. So if you go back to when I was learning this stuff, in order to be diagnosed with polycystic ovarian syndrome, you had to hit every box of about 10 different boxes. You had to have no more than 3 periods a year. You had to be overweight. You had to have extra hair growth. You had to have specific hormonal imbalances. You had to have specific ultrasound appearances of your ovaries. And if you didn't have them, you didn't have PCOS, which is nonsense, because somebody might have 9 out of 10 of them, and they definitely had PCOS, but sorry, don't qualify.
Don't tick my box.
Just daft, indeed. Now we know that what we used to call PCOS is actually probably 4 or 5 different conditions that are all been rammed into the same bag and mislabeled. So there's high androgenic and low androgenic PCOS, where people have high testosterone or low testosterone. It behaves in different ways. So the label is really, really unimportant. And that's what I'd love to see people move away from. Oh, I have been diagnosed with this. And stop. Are you trying to get pregnant? Are you menstruating? They're the 2 key questions. Are you overweight? Is it difficult for you to lose weight? How do you tackle the specific issue that is on the table, as opposed to, I have specific issues, I need to get a label, then I need to manage that disease? No. You need to manage you. So if you aren't getting periods and you're not trying to get pregnant at all, then it's maybe not a terrible idea to go on something like the combined oral contraceptive pill, keep your estrogen ticking over, keep the lining ticking over, maintain good healthy bone density and good healthy cardiovascular systems. Great. If you are trying to get pregnant, well, you're not ovulating every month, so that's going to be an issue. I mean, if you're not ovulating, or if you have no idea when you're ovulating, you're only ovulating twice a year instead of getting 12 bites of the cherry every year, you're getting 2. So there's medications, and that can be quite easily fixed. Are you overweight? Are you underweight? Can you fix that?
Yeah.
How can you fix that? That's not an easy or a quick process. Putting on weight for people who are very, very thin can be extraordinarily challenging as well. Something we all tend to forget about.
Yeah.
People who are overweight, who have high BMIs, especially people with PCOS, and it's something you will see that's very characteristic of this cohort, is they struggle to lose weight.
Yeah.
And your heart goes out to them, because if you are overweight and you tell people that you are struggling to lose weight, everybody has that judgment then. Yeah, sure you are. Yeah, that's because you're eating too much. You're not moving enough. It's not a struggle.
We have a fat-phobic society.
Exactly. So, but it is technically harder for them to move that fat mass into muscle mass than it is for somebody else.
And is that all due to like a
hormonal dysregulation? Is the easiest way I can put it. And it's not impossible, but it takes more work in an already difficult environment.
And then if you're adding to that the fact that you're trying to do that in order to conceive, it's just this whole...
And it's never only one thing, is it? Everything feeds into the other thing. So that can be a challenge as well. So you have to decide, right, what's the problem and what are we trying to tackle
What's
here?
the goal,
Exactly correct. And that's what PCOS is. But the label is tremendously unhelpful. For me, I want to know how long I want to know what your hormone results are. I want to know what your ovarian reserve is. I want to know what your goals are. How quickly do you want to be pregnant? How much effort do you want to put into it? And then you can draw up a plan, almost a series of plans, a menu almost of, where do you want to put your scale? PCOS is very, very treatable, so I think most people who have that kind of issue, they do very well.
Okay. And we mentioned irregular periods. If someone has an irregular period, does that mean they're going to have trouble conceiving or that they're not ovulating? Oh God, no. I mean, and I think the other thing to note, if you have a regular period, I'm 85 to 90% sure that you're ovulating every period. But one of the misnomers is that on average cycle is a 28-day cycle. So everybody thinks you ovulate 2 weeks after your period. You don't. You ovulate 2 weeks before your period. Okay. But on a 28-day cycle, it's the same on both sides. But if you've got a 40-day cycle, you're probably ovulating late. You're probably ovulating around day 25. Sure, because it's before the period.
Exactly. Yeah. And that's what triggers. So you're spending a longer time in that follicular phase, growing that follicle up before it releases. So long cycles. But if it's medicine defines, and again, this is old white dude stuff, defines an irregular cycle as anything, I think, outside sort of 24 to 36 days. Oh, so that would be a lot. You've all got a regular cycle. It's fine. It's like, I really don't feel like I do. Last month it was 25 days. Now it's 35 days. It doesn't sound regular to me. You're fine. So, but I guess when you're thinking about things physiologically, what can throw your cycle away? I've had 3 people in the last 2 days say to me that ever since they got their vaccine, their cycles have been out of whack. Yeah. I don't know of any evidence. I don't know of any research that's been done around this space. I don't know if it's coincidental. We know a lot of things can affect cycles, so it's possible, but it goes to show there's a lot of subtlety to this. Sure. Lots of things can throw people. Yeah, like stress and sickness and... all the life. Just, all the things that affect your body in other ways, But if you don't have a regular cycle, it can, of course, be more difficult to conceive, because I can't speak with the same level of surety that you are ovulating or that the environment is correct for the embryo to implant.
Okay, so let's talk about endometriosis.
So, okay, first and foremost, what is it? So, the endometrium is the lining on the inside of the womb. It's a really specific type of tissue, and it does amazing things. The uterus is an amazing
magic.
Organ. It's really an amazing organ. Like a uterus is normally about yay size, and about the size of a...
Oh, it's incredible.
What do we say? A small melon? I remember trying to describe ovaries, and I couldn't. I was like, don't say walnuts, don't say walnuts. Walnuts. But finding the appropriate size fruit is just a ridiculous game.
Don't you love when they do fruit for babies as they grow? Or sorry, this is completely digressing, but
no.
I had an app for, telling me what my baby was as they were growing, and you could change it so it would either show you the fruit or it would show you the animal.
Oh, wow.
The animal version. And it was all these really random like weasels and weird.
But at least the fruit is generally regularly shaped.
I know.
You don't want to think you're it's a weasel now. It really...
It was really weird. It was well, maybe if it was squished right up. Yeah, it was very strange.
Oh, wow.
But all the weird and wonderful fruits that you can...
Kumquats and kiwis. You know what world you're living in now, don't you?
So what size would a uterus be?
A uterus is probably the size of a grapefruit, give or take.
And would that expand during a cycle?
No.
It would just
but during a pregnancy, obviously, it gets substantially bigger. What it does during a cycle is the inside of the womb grows and then sheds. So as the egg is developing, the lining of the womb is thickening and thickening. Then the egg releases, and over those next few days, the lining of the womb becomes receptive, so that the embryo that comes into it is a window of implantation, about 5 days or so. An embryo comes in, it's ready to accept it.
So the only reason it's growing its lining is in case there's a pregnancy?
Yeah. We're a hemochorionic species, which means to say every month we develop the lining of the womb and then it sheds off. It's quite an inefficient system, but it's a really good nurturing environment for an embryo to go into. It means there's a huge, rich blood supply which allows development of very strong fetuses.
Yeah.
And that's how it's happened evolutionarily, we think, speaking. So if a pregnancy goes in, then the lining holds and the progesterone and HCG hormones hold onto it. If a pregnancy doesn't go in, then it sheds off.
Okay. So what happens if you have endometriosis?
So if you have endometriosis, that very specific type of tissue, which should only ever occur in the uterus, occurs outside the uterus, in the ovaries, on the fallopian tubes, on the ligaments, on the bowel. You can even get it in scar tissue. Wow. You can get it in gums. It's rarer, obviously, in belly buttons. And every month, that tissue responds to the same hormonally mediated cycle. So it grows and it sheds. But of course, it doesn't shed because there's nowhere for it to shed.
So if it's in your fallopian tube, where is it going?
It just causes irritation. You can get some bleeding and it'll be absorbed in the peritoneum. In the ovary, you get cysts forming in the ovary, and they're called chocolate cysts, which is a terrible misnomer. Well,
that's terrible because that sounds lovely.
Yeah, it ain't. They're filled with this horrible brown sticky fluid, and what that is, that's altered blood, because every month that little bit of endometrial tissue grows, bleeds, sheds,
and it just stays there.
So it gets encapsulated and walled off by the ovary. And then that cyst gets bigger and bigger and bigger. And of course, this is all filled with these inflammatory markers and these high cytokines and things of that ilk. So it can cause scarring. It can cause, even with mild endometriosis, you can get severe fertility changes. But at its most severe, at stage 4 endometriosis, the pelvis can be what's called frozen and filled with this horrible rigid scar tissue, which prevents anything from working well. The way we grade endometriosis is on a 1 to 4 scale, which is based on surgical observation of what we can see. The problem is that the degree of subfertility that's caused by endometriosis correlates very poorly with the grading. So on one end of the spectrum, you can have people with very severe endometriosis who are getting pregnant, and on the other end of the spectrum, you have people with what's called mild endometriosis who can have very severe symptoms or real fertility issues, And yet they get told when they have their surgery or a laparoscopy or what have you, oh no, your endometriosis is very mild. And they're like, well, it doesn't feel very mild. I don't know if you've ever heard of The Onion. It's a parody newspaper that's been produced in the States for years. They had a headline there last week which really did resonate, and I think it's a take-home lesson. So, woman puts off going to doctor until symptoms severe enough for him to believe her.
Yeah.
Yeah.
Sounds pretty accurate.
Achingly, depressingly, awfully familiar. And I think endometriosis very much lives in that space where people are told they have mild endometriosis, but they're crippled with pain. They are crippled with pain.
I have quite a few close friends who suffer very badly.
You know, and again, old white dude saying, oh, your endometriosis is mild. That's singularly unhelpful. So how we grade it and how we manage it, again, no more than with the PCOS, we should be looking at the symptoms. What does endometriosis cause? It causes pain. Pain with periods, pain with intercourse, pain with bowel motions. It's pain related. It doesn't necessarily cause heavier periods, although you can get a kind of endometriosis-like syndrome called adenomyosis, which is where you get endometrial tissue in the muscle of the wall of the womb, which can cause, again, this big inflammatory change. Again, you'll see a bit of a swelling in the uterus there. And that can cause heavier periods too.
So how does it prevent a pregnancy occurring naturally?
So what's interesting is endometriosis has an impact on every single aspect of female's fertility. So it'll have an impact on egg numbers, egg transport, sperm transport, embryo transport, and implantation. So egg numbers, egg quality, everything.
So everything is harder.
Everything's harder. The one it probably has the least impact on is implantation, but depending on how severe it is, with the caveat that we're limited in our understanding of this. So we know, even if you have very mild endometriosis, like a couple of spots dotted around the pelvis, if you analyze the follicular fluid, the fluid that the developing egg matures in somebody with mild endometriosis versus somebody who has no endometriosis at all, even if that endometriosis is not in the ovaries, you're still going to see differences in the immunological markers within that follicular fluid. And there'll be more pro-inflammatory cytokines and whatnot in the endometriosis. So sufferers, follicles. So we know it's having an impact on eggs right out of the gate. You know, we don't quite know what causes it. There was a lovely theory of retrograde menstruation. So the lining of the womb goes up through the tubes and falls into the pelvis and sticks there and lodges there. You can see evidence of endometriosis at fetal stage. So it's not that. You know, there's other factors involved as well.
And what is the treatment?
So it depends what the problem is. Again, rather than labeling somebody, you have endometriosis, you are a human being who is suffering with A, B, and C.
So I suppose for us, if, you know, people coming to therapy are obviously usually wanting to get pregnant.
Yes.
So if someone presents to you, they have a previous diagnosis of endometriosis.
Yep.
How would you treat them?
So you can either try to get them pregnant with fertility assistance, be that IUI or IVF, or you can do surgery.
And what is the surgery?
The surgery would be excision and removal of the endometriosis, a laparoscopy, keyhole surgery, or an open surgery, more commonly laparoscopy in this day and age, to try to remove or zap the endometriosis and improve their fertility.
And then after that, you would try to do IVF, or you would see if it would happen naturally?
So here's where you get into the controversial area. And if you had spoken to me before I started working purely in fertility, one of my interests was minimal access surgery. That's what I did for years. I was fortunate enough to work in the Mater when they started doing laparoscopic hysterectomies there. It was all very exciting. And it was cold steel to heal all the way. You know, this is how we fix our problems. And I'll declare my bias here. To a hammer, everything looks like a nail. If you're a surgeon and you see somebody with endometriosis, your suggestion is going to be, unsurprisingly, that they should probably have surgery. If you're an IVF specialist and you see somebody with endometriosis, your opinion is probably going to be that they should do IVF. Okay? So there's a huge amount of controversy between what's the best approach. Over the last few years, the data is emerging that if you have endometriosis and you want to get pregnant, fertility treatment is probably the best way to go. And that's becoming clearer, especially if you have, and these words are caveated, mild endometriosis, that zapping that endometriosis off doesn't appear to have a massive impact on your ability to conceive. If you have endometriosis, you should certainly be proactive. And there are conditions whereby if there are a lot of cysts in the ovaries, surgery can be indicated. There's no question about that, and I'll happily refer somebody to a good surgeon. But the problem you have there is you really need to go to a surgeon who is very respectful of the fertility component of your goals.
And why would they not be?
Well, because historically there's been a bit of a gap and a disconnect between obstetrics and gynecology and fertility. I didn't really learn an awful lot of fertility until I started working in the field. Mm-hmm. So most of the time you're going to see a surgeon for symptomatic relief because you're suffering with your endometriosis. Pain. And of course the easiest thing to do, the curative system for this, is take the ovaries away. You take the ovaries away, you remove the hormonal stimulation, you cure. You put somebody into menopause, you cure their endometriosis like that. So we have a fix. It's just not a fix you want to do. You're going there because, no, I'm struggling to conceive and my ovaries have these cysts on them. So then you have to take those cysts away. But the more carefully you do that procedure and you take your time and you really do very slowly peel off the cysts and you don't use any electricity to burn any bleeding points, you just use water dissection, you can preserve the ovaries. But that now takes an operation that would have taken an hour and now it's taking 5 hours.
Okay.
And there's people with cancer waiting outside.
Yeah.
And it's really hard to get people. There's plenty of people in Ireland with the expertise to do these kind of very complicated, convoluted surgeries.
But perhaps not the resources.
Indeed.
Okay. So it is completely possible for people with endometriosis to become pregnant.
Very much so. Very much so. I think if you've got symptoms that you think are suggestive that you might have endometriosis, or if you have a strong family history, if your sisters, your mum have endometriosis, that should ramp up your awareness of fertility. Get the AMH done earlier, get a scan done, see what the story is. The only way to definitively diagnose endometriosis is with surgery, but you'll see severe endometriosis with an ultrasound scan. So there are things you can do. I'm not proposing everybody goes off and has surgery. For the most part, if somebody says to me, I think I might have endometriosis, what should I do? Well, if you want to get pregnant, you should think about doing fertility treatment. Yeah. I don't think it's worthwhile, and there are people who disagree with me, and that's fine, but I don't think it's worthwhile enough doing a laparoscopy, a surgery, as a first line investigation. Sure. Despite the fact that it is the best way to look inside the pelvis.
Okay. So moving on, there is a common misconception that infertility or subfertility is always the woman's fault.
Yeah.
Like just constantly I hear this, and that's not true.
No. Do you have any idea what the percentage of couples would have a sperm issue? Have you?
Now that I know, I think it's about half and half. Is it?
Yeah, maybe 45% boys.
Yeah.
Some degree of male subfertility in approximately half of all cases we see. So, yeah.
Well, first of all, it's important to point out that it's no one's fault.
Yes.
You know.
Yes. Oh, yeah.
Infertility is no one's fault.
The language we use isn't always as respectful enough of that truth as it should be, but it's absolutely worth saying. So, this is about problem solving, diagnostics and treatment all the way. So, at least half the time, when a couple are struggling to conceive, you will see something on the semen analysis. Now, you need to be a bit careful about semen analysis because it's only a single data point in time, and they can go up and down. Every single Hollywood depiction of an abnormal semen analysis that I've ever seen, the man or the couple have gone to see a fertility specialist who talks about one thing and one thing only: stress. Every single film, I swear to God, you can start rattling them off. I was like, and while it's a factor, I don't think I've ever said the only problem here is you're stressed. I've never said that, and it got to the point where I'm going, am I bad at my job? Am I missing something here? That this is all about stress? Because it's not. But some people have very, very sensitive sperm. So small changes in lifestyle and diet and stress levels and cortisol levels can have an impact on sperm. You know? What
are the main things that have an impact on sperm quality?
Diet, lifestyle, smoking, alcohol, caffeine. We know THC, marijuana, can increase the fragility of sperm DNA. Okay. You know, it doesn't necessarily drop count so much, but it can increase the fragility of the DNA, I think. But being overweight, having other comorbidities, other diseases like high blood pressure or pro-inflammatory conditions can have an impact on sperm. That being said, you'll see some guys and they're hopelessly out of shape and they've got a terrible lifestyle
and they're excellent sperm.
Oh my God.
And then I'm sure the other side of the spectrum, you can get people who are super
Mr. Hardbody, and he's doing everything right. Now, the other thing, as I say, Mr. Hardbody, steroids is the big riser at the moment. More and more people are using testosterone, PEDs, steroid therapy to help build muscle mass.
And would that have a long-term effect on your sperm?
Usually not, potentially yes. So some people it can take, if there's loads of different ways. I didn't realize as I was learning to be a reproductive endocrinologist that what I was actually learning to do was be really good at getting people like doping. I now know how it works, and I never did before. So I could make a fist of that,
little side hustle.
Yeah. So there's ways you can take TRT with trying to minimize that impact, but a lot of it depends on the type, the duration. It's a very unregulated marketplace, so you're not quite sure what you're getting or what you're using. Some men, it'll knock out their sperm production completely, and in a proportion of those changes can be irreversible, yes.
And would you think that in that case, if this is completely off topic, but would it be an idea for people if they really do want to go down that route, but they do want to have kids in the future, to perhaps freeze them?
100%. 100%. And I think what we should be really trying to do is, rather than saying, I can't believe you use TRT, because I think it really is very, very commonplace now. Yeah,
and everyone's going to do what they want to do.
This is it. So rather than stigmatizing it and saying you need to have, if you're going to do it, freeze some sperm and at least have that as a backup. I would love to see more sperm freezing happen.
Yeah, because it's not that common.
It's very rare. And I mean, when we think of sperm freezing, we've generally historically thought of it in one of three ways. I'm going for treatment as part of a couple and I'm not going to be available on the day. Fine. I have been given a diagnosis of cancer and I'm going to be rendered azoospermic by surgery or chemotherapy, or I am an FTM trans and I'm thinking about backing up. And that's fine. But we should really be throwing it wider than that. We should be thinking about people who are using TRT. We should be thinking of doing this as a routine for anybody who's about to have a vasectomy. Yeah. It's so easy to do. Yeah. And
it's a lot easier to freeze sperm than it is to freeze eggs.
Yes. Yeah. Yes. So you say.
It is. Let's be honest here.
Yes, it is. So under those, I mean, I'm not saying the number of men who want to have a child post vasectomy is high, but those men who want to have a child post vasectomy, they're undergoing reversals, which have very, very variable benefits, and a lot of those men wind up having to do IVF or ICSI anyway. So if you had sperm frozen there, again, how accessible is it? How easy is it? How much hassle is it? What's the cost? All that. You have to parse that out. But if somebody's going for a vasectomy, I'm not proposing that somebody a female who wants to be sterilized, have a tubal ligation, should have her eggs frozen. Okay, but that's because, as we just said, egg freezing is difficult, and generally those people are a little bit older anyway, so the eggs are of lower quality. Most guys who have a vasectomy, the sperm is still fine. Yeah. And it's relatively easy to do, so why wouldn't it be routine to offer it and done in the majority of cases? It just doesn't make sense to me.
Yeah. So let's talk about age. We kind of touched on it. Obviously, I think everybody knows at this point that as you get older, it can be more difficult to conceive. Why is that? And is it different for eggs
and sperm? Yeah, so it is different, but also not. So everything gets worse as you get older.
Just in general in life.
You make a noise when you stand up, and then you know, oh wow, I've hit on something there. So very, very clearly, we know full well that eggs decline as you get older, and that decline probably starts in your 30s and gets much, much worse.
But it can start earlier, right?
100%. Okay. Yes, of course. But I'm just speaking the generality. Yeah. We used to think that sperm wasn't amenable to such changes. But now we know it is. Sperm counts drop as you get old. Sperm counts are dropping anyway. We'll circle back to that. Sperm counts drop, motility drops, quality drops. The degree of fragmentation in the DNA rises as you get older. The thing about sperm is, though, you've got millions of them.
Yeah.
So you've got a higher
and they
weight.
Regenerate. Don't they? Well,
yeah, it's sort of the same thing.
Wrong...
Yeah, no, but they turn over.
But you're not born with like a limited number of sperm.
No, not in the same way as with eggs. But you do regenerate, so you can change, and because you've got such a weight of numbers on them, that the good sperm tend to work out longer. But certainly, as you get older, as a male, you are more likely to give sperm that will contribute to a child which will end in miscarriage or a chromosomal or structural problem. No question about it. As you get older, it does get worse. Not to the same extent as it does with women. They outstrip men badly as they get older. The effects are much, much more, but it is still there. And usually back in the past, a semen analysis would be a standard test that we do for everybody, every male coming through. If somebody's the other side of 40, now I would generally also recommend doing a DNA fragmentation test as well.
And what is that?
So, do we have 2 or 3 minutes?
We do. Go for it.
So, all cells in your body have DNA in them. Mm-hmm. All right? And that DNA is the blueprint for how to make and maintain a cell. DNA gets damaged every day. Anything that stresses a cell, oxidative stress, cosmic radiation.
Like sunlight.
Things that damage cells damage the DNA within cells.
Okay.
Cells have the ability to repair their own DNA. Patch it back up and carry on. When a cell loses the ability to repair its DNA, it triggers its own cell death a few days later. It's a thing called cellular apoptosis. It's one of the major reasons why...
Sounds awful.
Well, no, it's why your skin flakes off. It's that core mechanism for how we regenerate ourselves. It's really, really important. Sperm are different. Sperm cannot repair their own DNA and will not recognize when that DNA is damaged. So as a compensatory mechanism for that lack of ability, the DNA in sperm is coiled and packed more tightly than it is in other cells, making it resistant to damage from oxidative stress. What a DNA fragmentation index does, to a greater or lesser extent, is not tell you how damaged that DNA, but rather how susceptible to damage it is, how uncoiled or unraveled it is. Because the more it is, the more likely it is to get damaged. The sperm doesn't recognize that the sperm has damaged DNA, so it contributes a defective blueprint to the egg to make a defective blueprint for the embryo, which will result in failure or miscarriage.
Okay, so if you had a DNA fragmentation done and you were faced with these results... And
it was high. So half the time, 50% of the time, the changes, you can resolve it to a greater or lesser extent with diet, lifestyle and supplementation. Half the time you cannot. And this is where our understanding of this whole thing becomes very, very imperfect. And there's lots of theories and there's loads of different ways of measuring this. And I'm sure if there's experts listening, they'll be going, oh, he's wrong. He's not talking about this. I've given very much a Cliff Notes version of this. But some people it's very amenable treatment, some people it's not. It's still controversial in that you could make an argument, oh, that's completely irrelevant. But we're kind of thereabouts. It definitely has a role to play. And it's another way, and perhaps we think that DNA fragmentation rises as you get older. And so if you're not seeing a diminution in sperm in terms of the count or the movement or the appearance of the sperm.
But maybe we are seeing a higher rate of fragmentation. Here's a question. Are sperm cells the only ones that don't do that within the body?
Off the top of my head.
That's just really interesting because it's like, why would it just be sperm cells? So
they found, if memory serves, and I'm really going out on a limb here now, they found out about it by accident. They were looking for
isn't that how
DNA fragmentation
a lot of stuff happens?
and repair in cells, and they just decided to use sperm. And then the sperm was suddenly behaving completely differently to how the theory had gone. Wait a minute, these aren't repairing themselves. Oh wow, there's something fundamentally different about sperm. I can't remember.
I'm going to have to go look that up.
Yeah. So I think there might be another one, but off the top of my head, I can't remember.
Okay, so here's a question. If someone came to you and there was female and male factor in fertility. They were getting a bit older, maybe early 40s. How likely is it that someone would have success with fertility treatment? And I know that's asking how long is a piece of string. That's like a completely crazy question. 7 is the number.
7. Yeah,
because a lot of people maybe have had unsuccessful cycles, and they just really want to know, is it worth putting myself through this?
So, yeah, I'm going to evade the question slightly, but try to answer it. Every single woman or couple who come in through the door of a fertility clinic, who have tests done and who are contemplating IVF or ICSI especially, we won't always get it right, but that person should be given a number, a raw number. And that percentage number they given should be the chances of a live birth from this completed process, doing it once. Okay? Now, you have to think cleverly. If you've got somebody young and you think you're going to get 4 embryos from a cycle, say, you do really well, you get 4 embryos. The fastest way to get that person pregnant would be to put all 4 embryos back in together. But obviously, we're not going to do that because it'd be mad. All right, we'll transfer the embryos.
We've talked about that before.
Yes.
It's mad to put in 4 embryos.
You'd have to be out of your mind to put 2 in if you were young and healthy.
Stop looking at me like that.
So you're thinking in terms of the cumulative chance of a live birth from all those embryos. Now, there's various little algorithm computer programs, IVF Predict and things like that, which will give you that information. If you spent long enough working in the field, you kind of have it in your brain already. You can do the sums. So what you have to do is 2 things. One, you have to tell that couple, we'll say couple just for the purpose of the conversation, you have to tell that couple what that percentage chance of a live birth from doing IVF is. And then the second thing, and it's a much harder task, make sure they understand what that means.
Yeah. Because
some people don't have a nod. And fair enough. They think that 5% is brilliant. They think that 95% is low. They think that the difference between 95% and 100% is the same as the difference between 0% and 5%. And it's not. It's not how these things work at all. So you have to make sure they can understand those numbers. And I do think you should write all that down. And I think that's at the core of what we should be offering as fertility services, because it's not our job to tell people what to want. It's not even our job to tell people what to do. Within the confines of safe, ethical practice, it is our job to make sure that the patients and the clients that we're caring for are appropriately educated to make those decisions themselves. So you said somebody mid-40s trying for a while, factors on both sides. The sad reality is, like in so many things, male factor is much easier to deal with than female factor. ICSI covers a multitude of sins. If we've got a good looking mobile sperm, ICSI will...
You only need one.
Exactly. So generally, if it's male factor, that's almost like a good thing. That's a problem with the solution. But if somebody's 42 years old, they might only have a 10 to 12% chance of a live birth, depending on circumstance.
And that's kind of per cycle.
And that's per cycle, and that's not high.
So you're looking at, you could be just doing cycle upon cycle, and even still, you're not, well, I guess anything in fertility is never guaranteed.
It was a number of years ago. I was with a couple. It was a little anecdote. And I was aware, just as the conversation was going, that she didn't have the same appreciation that I had, that we had challenges in this case. I hadn't met them before. So I was very gently and carefully trying to work ourselves to the point in the conversation where I can talk realistically about chance of success. So I was trying to be nice about it. So eventually I got there. I said, look, we can do IVF, we can do this, we can do the test, we can do this. But almost regardless of these test results, no matter how hard we try, your chance of having a baby from this process is 4 to 5%. And she got very upset. She became acutely upset, herself and her husband. We took a few minutes, got ourselves together, and continued the consultation. And during the consultation, we're still talking about the next steps and what we do. And she said, that number is so much lower than I expected to hear today, but it's still a chance, and I still want to go for it. I went, okay, think that's reasonable. And then she said, but still, 45%, that's terrible.
She thought you said 4T5 and not 425.
Yes.
Jesus.
And it was only that her husband...
He had understood, yeah.
And corrected her. So I didn't have to. Thanks be to the good God. So one, there's a whole pile of learnings to be taken from that. One, enunciation. Yeah, so get that right next time, John.
Better.
Yeah, speak good.
Speak good words.
And two, don't feel for a minute that you know what a patient's expectations are.
Yeah, because to you,
45%, knock it out of the park all day long.
Oh my God, 45% is like amazing.
Yeah, that's absolutely.
But to someone else, that might be very low.
That was very low, and to her, that was very, very low.
Yeah.
So that educational piece, and it has to be done sensitively, it has to be done carefully, but that's at the core of what we do. What we do, like fertility treatment, is limited. There's no question compared to other areas of medicine where, if you've got a problem with your appendix, you get your appendix taken out. You don't have a conversation with a surgeon who goes, look, there's about a 90% chance that this will go well. And there's about a 10 or 20% chance that we're just going to make a complete arse of it and you'll be in trouble. Like, there's risks with surgery, but they're small. Like, the failure rate for fertility treatment is so much higher than the failure rate in other areas of modern medicine. And we're doing our best and it's getting better all the time. But it still kind of sucks and it still takes a few efforts and it's still a long, hard road. So you have to get people on board at the start. You can't bounce away going, and we're all fighting against, it's okay if it doesn't work out, I'll just go and do IVF. It ain't that simple. That's why it all keeps coming back to education. Get educated at an earlier stage and then you might avoid those pitfalls, or if you do come in, you won't be talking to the likes of somebody like me who's giving you awful numbers that you just never wanted to hear in your life. Yeah. And then you head out to the car park and dissolve into floods of tears. Yeah. It's awful.
Wanted to end on two questions, putting you on the spot here with if you can pull from your memory two situations. So I'd love to hear if you ever had a case where it was very unlikely that it was going to happen and it did. And I
can think of one that
and how that was, and then the other side where it didn't work out. And I think we'll probably do a whole episode on how to deal with that.
Really good. So I remember there was a woman came in to me. She was single. She wanted to use donor sperm. She was 31 years old, and we did an AMH, and it was 0 point squat.
Wow.
Like, it was nothing. And she went off and she did some reading. Actually, she'd had the AMH before she ever saw me. So when she came in, she'd had it done. And she'd done some reading. She'd spoken to some people who said, no, you just can't get pregnant. It was real back in the day. Oh, that AMH, that's your fertility test. And what I said to her was, no, actually, look, this isn't terrible. It's not great news, but it's not nearly as terrible as you think. I think you're young. You're still ovulating. There's eggs there. You absolutely need to get moving now. And that was the kicker for her. She did not want to get pregnant at that point in time. It was one of those cases where she did the test to get the reassurance that she could.
And then she was faced with this information.
And she was faced with this horrific dilemma. And she took a little bit of time, came around, did treatment. I think it was only IUI she did in the heat of the hunt, and got pregnant. She was just disproportionately grateful, as some people are. So job, it's great, but she was so happy, and she was really happy that it had been a really crappy journey, but she got the outcome she wanted out of it, and there was all kinds of ups and downs with it, and that was very, very gratifying. I mean, I've had plenty of patients, see enough people where you're not waving a shroud, but you're being very honest and realistic about their chances, and then they just go and they just knock it out of the park. And they do brilliantly. And you go, okay, stay with the stats, John. Stay with the stats. You gotta, because you don't want to get carried away yourself. The ones that break your heart are the second cohort, where you've got somebody young and healthy, and you let your own bias get in the way. And much as you try to be reserved, you really feel
it's going to work.
It's going to work. Like, you have a little private conversation in the car. You're talking to her. Go, oh no, she'll get pregnant this cycle. We'd all be guilty of that. And I've learnt the hard way that it doesn't always work out that well, and just you can get lots of eggs and they can all be terrible, and now you're suddenly blink and you're 3 cycles in and you're 20 grand in the hole and you've had one embryo to show for your troubles and you're 32 years old and some doctor's talking to you about egg donation.
Yeah.
And that's heartbreaking.
Yeah.
That is really, really heartbreaking. And one of the reasons it's heartbreaking is because you feel like you got it wrong at the outset, that you weren't pessimistic enough with them.
Yeah. So maybe they would have.
And so I think they probably still have to go through it to get there.
I know.
But I've often thought, oh God, should I have been more? But again, you have to believe in the statistics. If I've got somebody who's 30 years old and they're coming in with tubal factor and everything else is fine, I know that with enough time and effort, if I can do a couple of cycles, I've got a greater than 90% chance that they'll have a baby at the end of it. With enough work, not necessarily one cycle, but with enough work, you get them across the line. But then that's not 100%. And the trap we're all guilty of is falling into 90 equals 100.
Yeah.
80 equals 100.
Yeah, if we just
0
keep doing
10.
it, eventually it will happen, because
course,
that's not true.
And of course, that's not what the statistics mean at all. But yeah, more often than not, you do live within that framework.
Yeah, well, I guess that's all part and parcel of this field of medicine.
Absolutely.
And the wonderful world of fertility.
My oh my.
Been lovely chatting to you.
You too. Let's do it again.